It's a pleasure to be here with you, and today I would like to talk about the screening and prevention of preterm birth in Hungarian population. I'm Balázs Komoróczy. I'm a resident doctor at the Obstetrics and Gynaecology of the Semmelweis University. I'm also a PhD student, and my supervisors are Professor Nando Rács and Zsófia Benkő. And we are working together with Szilárd Vancsa as a scientific methodology supervisor. Our vision is to prevent preterm birth, to reduce avoidable fetal and maternal complications. As a mission, we would like to develop a reliable screening model for pregnancy complications leading to preterm birth. Our specific goals is to investigate safety and efficacy of low-dose aspirin and to screen for spontaneous preterm births in singleton pregnancies. Our first project is a network meta-analysis and a systematic review, but we would like to investigate the different low-dose aspirin prophylaxis during pregnancy. Let me tell a few details about the background. Almost 5% of all pregnancies are complicated with preeclampsia. Low-dose aspirin is a well-known protection of the development of preeclampsia, and as well all the complications related to preeclampsia, such as preterm birth or intrauterine growth restriction. But it is well known and it is well studied. The optimal dose of low-dose aspirin has not been defined. There is no consensus about the optimal dose. Our aim is to investigate the safety and efficacy of different low-dose aspirins during pregnancy. As you have already heard a clinical question, we would like to investigate pregnant patients who are administered different low-dose aspirins compared to pregnant patients who are not administered any kind of low-dose aspirin or was aspirin with a different dose. Our outcomes are these are hard outcomes such as preeclampsia, preterm birth, intrauterine growth restriction, or small for gestational age, as it is also called. And we would like to also investigate the peripartum and postpartum bleeding. Our hypothesis that 81 milligrams of aspirin would be the most efficient to prevent preeclampsia. We conducted a systematic search from 3 databases using the following search key, and we found more than 4,000 articles. And by doing the duplication removal and doing the full text selection, there are 62 eligible full texts to discuss. We have already seen these, we have already read these, and we started the data extraction, and we made this network. As we can see, most of the studies are comparing aspirin to placebo, but some of the studies are comparing different doses of aspirin, and that's why we wanted to carry out a network meta-analysis. That's for the first project. Talking about the second project, we would like to screen for preterm births in singleton pregnancies. It's a protocol for an observational study but we would like to carry out as well in our clinic. Just a few things about the background. The incidence of preterm delivery, as we have heard today, it's almost 12% in all cases of pregnancies. The screening for preterm birth is one of the most studied challenges in obstetrics because there is limited intervention for preterm birth. Combined screening model using the second-trimester ultrasound screening for cervical lengths and obstetrics and behavioral maternal history seems to be a reliable screening model. Our aim is to translate cervical length screening into a better clinical practice, also in Hungarian population. As you have heard our clinical question, we would like to investigate the cervical length on the second trimester screening, and we compare the normal cervical length to the shortened cervical length, which means that the cervical length is below 25 millimeters. We would like to prevent as much preterm births as we can, as much preterm births as we can in Hungarian population as well. Our eligibility criteria, just a few things to tell about. We would like to include all the patients. We have to exclude patients with interventions, I mean cervical sacklage inserted patients, or patients receiving medication against preterm birth as well, but excluding them, we would like to examine everybody else on the second trimester screening include. The protocol drafting will be conducted for two groups. The group A will be the normal cervical length, and it will be compared to the shortened cervical length. The outcomes, or primary outcome will be the incidence of preterm birth, and as secondary outcomes we would like to measure maternal and neonatal outcomes as well. We would like to choose our outcomes as hard outcomes, as hard as we can. Thank you for your attention, and I would like to finish my presentation by a quote from Steve Jobs. If you are working on something that you really care about, you don't have to be pushed. The vision pulls you. Thank you.
Hello, my name is Christian Kovács from Group 6 Orthopedics. My question is that how did you identify that 81 milligram of aspirin in the first project? So why not 50 or why not 100 milligram?
In a previous meta-analysis that has been carried out, there are a lot of meta-analyses in this study because it is a hot topic in obstetrics. And it has been already found that below 75 milligrams of aspirin, it's not as effective as over 75 milligrams. But it's really hard to choose the optimal dose because of the bleeding consequences, taking aspirin regularly. That's why we would like to choose, and all the studies say that it might be somehow between 75 to 100 milligrams. And that's why 81 looks to be fair for preventing preeclampsia. 81 milligram of aspirin is not available in Hungary, as I know, but it is available in the United States, and we have really big studies using 81 milligrams.
So you're absolutely right with asking this question. This is a crazy thing. Why 81 milligrams? But in the United States they have got a preparation containing 81, and nearly all the studies use this preparation. So this crazy amount comes from those studies.
Hello everyone. I am Miklos Keszi from Orthopedics Groups, and as I understand it correctly, for your first project, you're planning to give aspirin as a prevention of eclampsia. Is it correct?
Yes.
Yeah, and how you decide to give patient aspirin or not, and in which trimester is it safe, and is there any side effects for aspirin? Is it safe to give it all over the pregnancy? Is there any harm for the baby development, or I would like to add this.
Thank you for your question. It's a really good question. Most of the studies started aspirin in the first trimester. Some of the studies who included patients with recurrent miscarriages started aspirin before pregnancy, before the implementation, before the validated pregnancy. A few of the studies only started aspirin after after the second ultrasound screening for patients with abnormal uterine artery flow. So it's really hard to define where to start, but it is from the studies, from the previous meta-analysis, it is shown that the sooner we start aspirin, the better effect it has. We usually stop aspirin at the 36th week of pregnancy because preterm birth we're no longer talking about preterm birth after the 37th week of the pregnancy. And by this, we would like to avoid preterm birth and preterm preeclampsia. If preeclampsia occurs after the 37th week, if we diagnose it, we trying to treat it, but if it cannot be treated, it may be solved by a delivery or by an abnormal vaginal delivery. If the newborn has already born, the preeclampsia will be solved in most of the cases. The neonatal outcomes for using aspirin does not show any differences between the intervention and the placebo groups regarding to bleeding complications or intracranial hemorrhage or any other outcomes.
Is there any known risk factors for preeclampsia? So
yes, there are a lot of risk factors for preeclampsia, but it is also something we have to work on because we know the risk factors for preeclampsia, but some of the studies differentiate risk of preeclampsia in different ways. That's why we have to read them well and try to make the common point.
If there is any significant side effect for the first trimester, then,
for aspirin?
Yeah, for aspirin, but then why don't we give everybody low dose aspirin to prevent? But because we don't know who will develop preeclampsia and not. Of course, there is risk factors for that. But if we just nothing special happens for the baby and for the mother, then why is it just give the mother?
Thank you for your question again. It's a really good question, and as I know, there is no any risk factor for taking aspirin, but for the patients, it's also important that they wouldn't like to take any medications during pregnancy. They have a fear against medications. They have a fear against any tablets we would like to give to them, and especially in pregnancies. Any known side effects has been reported in the first trimester.
So you have seen quite a few papers. And then you are kind of comparing those.
Yes.
Now, there was actually one group in your network meta-analysis which gave actually 0.5 milligram per kilogram. While most of the other ones, give just a kind of number which depends on the formulation actually of the medicine. Now, body weight is actually, changes in a quite wide range. So do you actually relate your data to the body weight of the patients?
Thank you for your
question. Can you do this?
Question. I think in our setting, it is not available
Except if that's in some of the papers.
Only in one paper,
Yeah, yeah.
we found that they could afford that aspirin was given by body mass index, body mass. I think we would need a pharmaceutical company to stand behind us to be able to perform such a study. But as you can see, most of the studies are using already available aspirin doses in their country. Of course, in our papers, it has been declared that which company was given the aspirin.